having done his undergraduate and medical school here before moving to Penn, where he did his residency and nephrology fellowship when the current dean here was actually chief of nephrology. And he then moved to Pittsburgh in 1989, where he has been ever since. He's a professor of medicine there. He is the chief of kidney medicine at the VA there. He also holds numerous national leadership titles, including as a deputy national executive director of the kidney medicine program, the VHA kidney medicine program. He's served in many organizations as chair of quality at RPA on the end-stage renal disease networks, and of course, until very recently, was president of the National Kidney Foundation. He is a phenomenal clinical investigator with over 300 publications, numerous awards, too many for me to mention here, with a focus on acute kidney injury as well as critical care nephrology. And he told me last night that it was Murray Levin, actually, who determined his path into nephrology. Perhaps no surprise to many of us who know Murray here. It has been my distinct privilege during my tenure at ASN to have had the opportunity to work pretty closely with Paul on a number of joint collaborative initiatives between the National Kidney Foundation and the American Society of Nephrology. So, Paul, we're absolutely delighted, and I think you brought the good weather with you as well. So looking forward to your talk.
Well, thank you for that very kind introduction. It's a delight to be back at Northwestern. As Dr. Quagman pointed out, I'm a graduate of the institution. I was a shunt, a 6-year med. I guess it's now a 7-year program. And I can remember my first contact with your dean was when I was an intern and he was moonlighting in the emergency room at Penn. So anyway, let me turn to the topic at hand here, which is timing of kidney replacement therapy in acute kidney injury. My necessary disclosures: I've been funded for my research by the VA, by NIDDK, and by the Canadian Institutes for Health Research, because I collaborated with some Canadian researchers in the START-AKI trial. And I've done completely unrelated consulting for Janssen. Let me start with a clinical case. You're consulted in the ICU for possible initiation of kidney replacement therapy for an 82-year-old man who has developed oliguric AKI following an emergent CABG. He had a history of hypertension, type 2 diabetes, and COPD, but actually had perfectly normal kidney function with a baseline creatinine of 0.9, no albuminuria. He presented to the hospital 5 days earlier with severe chest pain. He had a non-ST segment elevation MI, goes to the cath lab, has an emergent cath, which demonstrates severe 3-vessel disease, and surgical management was recommended. 2 days ago, he had a 5-vessel CABG. Postoperatively, he's hypotensive, requiring vasopressor support with epinephrine and norepinephrine. His initial cardiac index was low at 1.3 liters per minute per meter squared, and has progressively improved to 1.9 yesterday, and now it's up to 2.2. He has been weaned off the epi. He has a blood pressure of 110/60 on a whiff of norepinephrine. On exam, he remains intubated, sedated, mechanically ventilated. He has decreased breath sounds over his left chest. He has 1+ pedal and flank edema. He's oxygenating with an O2 saturation of 98% on an FiO2 of 0.4 with minimal PEEP. And he's been in markedly positive fluid balance as shown. And his creatinine has gone up to 3.1, BUN of 42. He's a little hyperkalemic at 5.6, and his total CO2 has drifted down to 19. So the question, do we start? CT surgery really is pushing to start continuous therapy, or do we watch and wait? Manage medically, control the hyperkalemia, supplement his bicarb with alkali, and try to diurese him. And this has been a recurring question. I mean, we deal with this day in and day out in our own practice, but this is a question that really has been present in nephrology for decades. And this is a quote that I love. While there's increasing recognition of the value of earlier dialysis, the published consensus and the practice in many centers at present is still to apply dialysis to relatively ill rather than to relatively healthy patients. And part of the reason that I love this quote is that it was published before I was in nursery school by Paul Teschen and colleagues from the Army Medical Corps, publishing their experience from the Korean War and post-Korean War experience doing prophylactic dialysis. Actually, this was the first description of prophylactic dialysis in the American literature, published in the Annals of Internal Medicine in 1960. And we've been having this debate. Do we start earlier or do we wait for, at this point, it's more than 6 decades. Now, we should recognize that the debate has changed over time, and what we consider early and late in 2022 is a little different than what was early and late in 1960, but it's still a fundamental question. I think we can all agree that there are some very clear-cut indications for emergent initiation of dialysis. Volume overload, unresponsive to diuretic therapy. But how do we define volume overload? What constitutes volume overload severe enough that the patient needs to start? Metabolic acidosis. But metabolic acidosis due to what? Metabolic acidosis due to the renal failure? Certainly. Metabolic acidosis due to lactic acidosis? Can we change the patient's outcome by dialyzing them for lactic acidosis? If it's metformin toxicity, probably yes. If it's the lactic acidosis of sepsis, probably not. Hyperkalemia, how severe? Greater than 5.5? Greater than 6? Greater than 6.5? How aggressive should the medical management be? Uremic state? Well, rarely do we see pericarditis as a complication of AKI, and it's hard to identify uremic encephalopathy separate from the multiple other reasons for altered mental status for the patient in the ICU. And there's that white stuff that's often infusing into the patient, the propofol, that makes it absolutely impossible to assess altered mental status. So the vast majority of patients, we're dealing with the question of azotemia without overt uremic manifestations or persistent AKI. And some of our critical care colleagues, and some nephrologists even, would argue that we should be starting patients on dialysis merely for persistent oliguria, oliguria that's present for more than 12 to 24 hours. Are there data to support this or to guide the timing of therapy? Well, there have been lots of observational studies and small prospective studies that have been done. This is a meta-analysis that was published in 2012 with the literature prior to that point. And I will point out that at the time there were slightly less than 3,000 patients in all of these analyses. And if we look here at the, if I can get this there, at the risk ratio, it was 0.71 favoring early initiation of kidney replacement therapy, whatever early means in these studies comparing earlier to later treatment. But the observational studies have a fundamental problem. The observational studies take the spectrum of patients with AKI who are then managed either with an emergent start or no emergent indication for kidney replacement therapy, and analyze them based on whether they received early or late therapy. So the early group includes patients with emergent kidney replacement therapy where we don't really have a clinical question. This is a life-saving treatment. And they don't include the patients who did not have an emergent indication who never received kidney replacement therapy. So we have this analysis that may not be looking at the correct patient population. When we do a clinical trial, we're generally going to exclude patients who have an emergent indication because there is no clinical question here. These are patients who the vast majority of us looking at the clinical situation says, yeah, they need to be treated. There is something in the presentation. They have fulminant pulmonary edema. We're not going to be able to oxygenate them unless we get fluid off. They have life-threatening hyperkalemia in the setting of rhabdomyolysis with a potassium of 8.5. We're not going to be able to control that medically. So this is not a patient where we have clinical equipoise. The question is in the patients who we do have clinical equipoise, where there is no immediate indication, and then those patients can be randomized to an immediate start strategy or a delayed strategy. And in that delayed strategy, we have to accept that there will be a substantial number of patients who, because we wait, either die without receiving kidney replacement therapy or survive without being exposed to kidney replacement therapy. So let's look at the recent trials, and there have been a number of trials done since or published since 2016. The first two of these were published within days of each other. The Elaine trial published in JAMA, and the Akiki trial published in the New England Journal of Medicine. And two very different trials. The Elaine trial took patients in a surgical ICU who had stage 2 AKI, defined either on the basis of change in serum creatinine, so that's a doubling in serum creatinine, or on the basis of oliguria for 12 hours. The patients had to have an elevated NGAL because it was thought that that's a marker of progression, risk of progressing to more severe AKI. And they had to have one of the following: severe sepsis, use of vasopressors or catecholamines, a non-renal organ dysfunction, or refractory fluid overload. Okay? Refractory fluid overload, that many of us would say that's an indication for immediate initiation of therapy. And there were no exclusions for electrolyte disturbances or other indications for emergent therapy. And then the patients were randomized either to early kidney replacement therapy, starting within 12 hours, or late therapy, where they were to be started within 12 hours of reaching stage 3 AKI, defined either on the basis of change in serum creatinine or urine output criteria, having a urea greater than 200 milligrams per deciliter, a potassium greater than 6, a magnesium greater than 8, a urine output less than 200 ml per 12 hours, or organ edema with diuretic resistance. So those were the escape criteria. And what was seen? So there were 231 patients enrolled in the study, 112 randomized to early, 119 to late. All 112 randomized to early therapy received kidney replacement therapy with a median time to start of 6 hours. In the late arm, 108 of the 119, or 91%, received kidney replacement therapy with a median time from when they hit stage 2 AKI of 25.5 hours, so the difference was 21 hours between the two treatment arms. And you can see serum creatinine at kidney replacement therapy initiation, 1.9 versus 2.4. And the primary endpoint was 90-day all-cause mortality, and you can see 39% versus 55%, a hazard ratio of 0.66, which reached statistical significance. So a 15% difference in mortality. There's very little in what's done in the ICU that achieves a 15% difference in survival. Here's the Kaplan-Meier survival curves showing the separation between the two treatment arms. And there was other differences. In the late arm, those who received kidney replacement therapy, the duration was 25 days versus 9 days in the early arm. Mechanical ventilation differed by 60 hours and a 37-day difference in overall hospital length of stay. This is pretty impressive for a 21-hour difference in timing of start of therapy, and raises concern in my mind that there were differences between the study arms despite this being a randomized trial. The Akiki trial took a very different approach. The Akiki trial, which was a multi-center trial done across a network of ICUs in France, enrolled patients who had stage 3 AKI. So Elaine, stage 2 for enrollment, and late therapy was stage 3. Akiki doesn't enroll until stage 3. Patients were excluded if their BUN or if their urea was greater than 40, corresponding to a BUN of 112, K greater than 6, pH less than 7.15, or if they had pulmonary edema. These patients needed to be started on therapy. They received non-study therapy. If there wasn't an emergent indication, they either were randomized with it, and started on kidney replacement therapy within 6 hours, or randomized to the delayed arm where kidney replacement therapy wasn't started until the urea was greater than 40, that's 112 milligrams per deciliter. If the potassium was greater than 6, if they developed severe acidemia, if they had pulmonary edema, or if they had persistent oliguria for more than 72 hours. If they didn't have an indication, they did not have to receive kidney replacement therapy. So they enrolled 619 patients, 311 in the early arm, of whom 305, or 98%, received kidney replacement therapy. The median time from stage 3 AKI to initiation of therapy in the early arm, 4.3 hours. In the late arm, only 157 of the 308 patients ultimately received kidney replacement therapy, or 51%. Those who did started dialysis at a median of 57 hours after reaching stage 3 AKI. So big separation time-wise. A lot of patients not receiving kidney replacement therapy. Difference in serum creatinine, 3.3 versus 5.3. You can see the difference in the number of therapies, kidney replacement therapy sessions, but the median number of treatments per patient, essentially the same. 3 versus 4, 28-day and 60-day mortality, essentially no difference between the two treatment arms. This figure illustrates the separation between the two treatment arms. So you can see virtually everyone in the early arm received early kidney replacement therapy, and only half of the patients in the late arm. And here we have the overlapping survival curves. Now, I will point out that of the patients in the late arm, randomized to the late arm, who did not have kidney replacement, or of the patients in the late arm, those who did not have kidney replacement therapy had much better outcomes than those who did receive kidney replacement therapy. Or another way to say that is, if you received late kidney replacement therapy, you didn't do as well as if you were in the early arm and received early therapy. But those are not comparable groups, and that is an inappropriate comparison to make because they are very different populations. When we look at other outcomes in terms of kidney replacement therapy free days, given the fact that half the patients didn't receive kidney replacement therapy, there were more kidney replacement therapy free days through day 28. No difference in ventilator free days, no differences in ICU or hospital length of stay when analyzed either on the basis of all patients, surviving patients, or non-surviving patients, and a higher rate of catheter-related bloodstream infections in the early arm, a rate that was essentially double the rate in the late arm, corresponding to the fact that there were twice as many catheters in the early arm as in the late arm. Now, at the same time that the Akiki trial was underway in France, a second trial was also underway in France called the Ideal ICU trial. This was a study looking at sepsis-associated AKI. The entry criteria, presence of sepsis, and rifle F AKI. Now, rifle F is essentially the same as KDIGO stage 3. Patients were excluded if they were hyperkalemic, acidemic, or had pulmonary edema because they needed to start on kidney replacement therapy. There wasn't equipoise for treating those patients. For the patients without an emergent indication, they either started on kidney replacement therapy within 12 hours if they were randomized to the early arm, or if they were randomized to the delayed arm, they started on therapy if they developed hyperkalemia, pH less than 7.15, pulmonary edema, or after 48 hours. If they didn't recover within 48 hours, they were started on therapy. Slightly different criteria in the late arm for kidney replacement therapy. So what we saw, there were 488 patients ultimately enrolled in the study. The original target was around 850 patients. The study had to be stopped nominally because of futility, probably more because of the funding ran out. Slow enrollment. Of the patients in the early arm, 97% received kidney replacement therapy. In the late arm, 62% did. So 38% never received kidney replacement therapy. The median time from rifle F to start of therapy, 7.6 hours in the early arm, 51.5 hours in the late arm, slightly shorter separation between the two treatment arms because they were by protocol starting at 48 hours if they 48 hours after randomization. Only 17% of the patients in the late arm required initiation of therapy because of an emergent criteria. Metabolic acidosis in 8%, hyperkalemia in 4%, volume overload in 2%. No difference in mortality either at 28 days or 90 days, nominally a slightly higher mortality in the early arm, but essentially no difference. And here you have the Kaplan-Meier survival curves. And again, secondary outcomes, more kidney failure, kidney replacement therapy free days in the late arm through day 28, no difference in ventilator free days, no differences in ICU stay, and no difference in dialysis dependence at day 90 in surviving patients. So in that environment, Sean Bagshaw and Ron Wald from Edmonton and Toronto, respectively, put together a group to design and implement the START AKI trial. So this trial was designed to be the definitive study with a target enrollment of slightly under 3,000 patients. Patients were to be included with stage 2 or 3 AKI. In a pilot, they used an NGAL criterion as well, and it turned out NGAL didn't help differentiate those who went on to progress from those who didn't, because everyone who was screened basically had the elevated NGAL levels. So that was taken out of the study. Patients were excluded if they were hyperkalemic, had a low total CO2, and if the treating clinicians had an absence of equipoise. And either they received kidney replacement therapy as non-study therapy, or they didn't because the treating clinician said there was no need. For the patients who did not have an emergent indication and where there was equipoise among the treating clinicians, they either were started on kidney replacement therapy within 12 hours, that was randomization to the early arm, or if they were randomized to the delayed arm, they were to be started on kidney replacement therapy if they were hyperkalemic, acidemic, if they had pulmonary edema, and if they had AKI that persisted beyond 72 hours, it was up to the treating clinicians to start or not start at any point. So we had patients in the delayed arm who either received delayed kidney replacement therapy or never received kidney replacement therapy. Now, it's important to look at studies and look to see who actually gets included in the study. I didn't show this for the other studies, but for START-AKI, there were about 24,000 patients who were screened. Of those, half did not meet the inclusion criteria for a variety of reasons. There were just under 12,000 patients who were provisionally eligible. But of those, only around 3,000 patients were fully eligible. There were large numbers of patients where the treating physicians said they did not have equipoise. Slightly more than 2,000 where the treating physician said this patient needs to be started right away. We know the right way to treat this patient is to dialyze them or start continuous therapy. And just under 6,000 patients where it was the opposite. There is no need to start. This patient is going to get better. We don't think we should start now. We should wait. Now, some of those were rescreened and later started. And then there were some patients where they were excluded because there was no one around to give consent, or they were enrolled in another study where they couldn't be enrolled in this trial. So slightly more than 3,000 patients. Now, I said that the target was a little over 2,800. In fact, because of some patients dropping out, the DSMB recommended that the total study enrollment be inflated to maintain power. Of the around 3,000 patients, there were some that were lost either because they withdrew consent or they were found to be inappropriate randomizations, that they had an exclusion. A few patients lost to follow-up. So there were slightly more than 2,900 patients that were in the analytic cohort. And what was seen was that almost 97% of the patients randomized to the early arm received kidney replacement therapy within 6.1 hour, median of 6.1 hours from the time that they were fully eligible for the study, as opposed to just under 62% of patients in the late arm, and those who started about 31 hours from the time of full eligibility. So shorter separation in time, similar percentage of patients who never received kidney replacement therapy as in the ideal ICU study, slightly greater percentage dialyzed as compared to the Akiki trial. Fluid balance at the time of initiation of therapy, not surprisingly, was higher in the late arm. Potassium, minimally different. Total CO2, minimally different. No differences in 90-day mortality. In fact, 43.9 and 43.7%. The hazard ratio, 1.00. I don't think you can get closer. There was a higher rate of dialysis dependence seen among survivors in the early arm as compared to the late arm. Hazard ratio for dialysis dependence of 1.74. So the two panels here show the separation between the two treatment arms. This panel, the left panel, showing, showing the full 90 days, and the other panel showing the separation just over the magnified for the first 7 days. The lines at the bottom, the broken lines, are mortality, because mortality is a competing event for being able to initiate kidney replacement therapy, so that you can see that the reason that patients aren't being started isn't because of the high death rate, but that there was a higher death rate without kidney replacement therapy in the late arm than in the early arm. And here we have the overlapping Kaplan-Meier survival curves. Pre-specified subgroup analyses, no differences based on sex, baseline EGFR, SAPS-2 score as a marker of severity of illness, presence or absence of sepsis, whether it was a medical or surgical ICU patient, and because this was a multinational study with vastly different patterns of care by country, particularly when you look at Australia, New Zealand versus North America, no differences in the analysis by geographic region. Now, in the discussions as we were developing the statistical analytic plan, I had pushed hard that if the study did not demonstrate a benefit for either arm, that there be a pre-specified non-inferiority analysis. I lost that discussion. It wasn't built into the analytic plan, but what was built into the analytic plan was a Bayesian analysis, which essentially you can consider achieving the same goal. So here's the Bayesian analysis for the primary outcome of survival. And when you do a Bayesian analysis, what it's doing is giving you the probability of the result, and it is providing the analysis based on assumptions of prior probabilities. So this analysis was done using the top panel with a pessimistic, an optimistic, and a neutral analysis that earlier would be better. And then based on the results from the START AKI pilot, which was a 100-patient study, and analyses, an overall meta-analysis that that I had given you that showed the 71, the risk ratio of 0.71 favoring early initiation of therapy, the results from the Elaine trial, and the results from the Akiki trial. And you can see, if you look at the results from the Elaine trial here, that gives the greatest posterior probability that there was a benefit to earlier therapy, but it still is not strongly supporting earlier therapy. And then analyses looking at the combined outcome of alive and free of kidney replacement therapy. This analysis strongly supported a benefit to the delayed therapy and modestly supporting the early therapy for days alive and outside of the hospital. So the Bayesian analysis, I think, provides strong evidence that there's not a substantial probability that the results of the study might favor earlier kidney replacement therapy. Now, if we compare these trials, the Elaine trial clearly stands out as an outlier trial. All the other studies have consistent outcomes. And of course, once you have multiple trials, as seems to be the case in everything in medicine, we get a meta-analysis. And here is a meta-analysis that included all of these trials plus some of the older ones. And you can see that the overall outcome was that there was no benefit associated with earlier initiation of kidney replacement therapy. But that there was a signal, did not quite reach statistical significance, but a signal suggesting a higher risk of dialysis dependence with early kidney replacement therapy, with the bulk of that outcome being driven by the START AKI and the initial Akiki trial. Now, if we believe then that we should wait, pardon me, if we believe we should wait, the question is, are there boundaries on how long we can wait? So the French investigators who did the Akiki trial then did a second trial, looking, which they cleverly called Akiki 2, which took patients who would have been in the late arm of the first trial and held them even longer. So these were patients with stage 3 AKI who had a urea greater than 40, that's a BUN greater than 112, or oliguria for more than 72 hours, who were not hyperkalemic, acidemic, or had pulmonary edema. And they then randomized those patients to starting at that point, so this is delayed, or an even more delayed start, waiting until the urea was greater than 50, that's a BUN of 140, a potassium of 6, a pH of less than 7.15, or pulmonary edema. Now, they designed this trial with the idea that this would have no impact on survival, but that the more delayed arm would be associated with decreased healthcare utilization. What they saw was slightly different. So they enrolled 278 patients. 98% of the patients in the delayed arm received kidney replacement therapy, as opposed to 79% in the even more delayed strategy. The time to randomization, from randomization to kidney replacement therapy, 3 versus 33 hours. Kidney replacement therapy free days, not different between the two treatment arms. But what they did see was a signal for higher mortality in the more delayed arm, although the absolute mortality differences didn't reach statistical significance. The pre-specified adjusted analysis hazard ratio of 1.65 did achieve statistical significance. While this was not a primary outcome, it should stimulate significant caution regarding how we wait. So let me talk for a moment about fluid overload specifically, because there are many who argue that a degree of fluid overload, a specific level of fluid overload, should be a criteria for starting, even if we're going to wait longer. And there are studies, observational, that have said that the greater the fluid overload when you start kidney replacement therapy, the higher the mortality. This is pediatric data from Sutherland and colleagues, and you can see the markedly increased mortality associated as you go from less than 10% to greater than 20% fluid overload at time of initiation of therapy. All of these were patients who received therapy. The Picard study was an observational study, and again, if you were more fluid overloaded at the time of initiation of therapy, your survival was diminished. Finnish study, similar results, very consistent. Doesn't matter whether you're an adult or a child, whether you're in the United States or in Finland. More fluid overloaded at time of start of therapy, the more likely you are to die. Does that mean that it's the fluid overload that's driving this? So this is an observational study of cumulative fluid balance in survivors of non-survivors of continuous renal replacement therapy. The more fluid overloaded at day of initiation, the higher the mortality. The more likely you are to be in the non-survivor versus survivor group. The degree of fluid, the cumulative fluid balance, the maximum fluid removal during continuous therapy, again, more fluid in the non-survivor than the survivor group. But when they looked at this in a multivariable analysis, the results became more interesting, I think. Older you were, the more likely that you died. The higher the SOFA score, the more likely that you would die. The higher the pressor dose, the higher the mortality risk. However, in this adjusted analysis, cumulative fluid balance at continuous therapy initiation is no longer statistically significant. And the fluid removal that you achieve remain statistically significant, suggesting that it's your ability to remove fluid that may be the determining factor. Now, in a post hoc analysis from the START trial, what was seen was that the degree of fluid overload at initiation of therapy was not statistically associated with mortality. More fluid overload, there was the slope seemed to favor a higher mortality, but this was not statistically significant. So what do we have? The degree of volume overload is clearly associated with mortality. But the underlying disease is probably driving, or the response to underlying disease, the degree of volume overload. So the model probably looks more like this. Underlying disease drives volume overload, drives mortality, and we don't really know how much the volume overload is specifically driving mortality. And I don't think we have data in 2022 that tells us that a specific percent volume overload should dictate when we start. Now, a patient who's volume overloaded, has cardiopulmonary compromise, and isn't responding to diuretics, obviously that's a patient who should be treated. But if a patient is still being resuscitated and they're pouring that fluid into their extracellular compartment and they're oxygenating fine, starting them on kidney replacement therapy because of some percent volume overload just doesn't make sense. And finally, there are arguments that have been made that we should be starting people on treatment just to remove cytokines. And this has been looked at in sepsis. This study from Europe that did not show any benefit. Actually, it showed worse outcomes with this attempt at management. The HEROICS trial was a non-sepsis trial. This was patients with cardiogenic shock after cardiac surgery. Again, not associated with the idea of very high hemofiltration for cytokine manipulation, did not show a benefit. So where does that leave us in 2022? In patients with severe volume overload or potentially life-threatening metabolic disturbances associated with AKI, if it's consistent with the patient's goals of therapy, kidney replacement therapy should be promptly initiated. I don't think there's any question there. In patients without an absolute indication, a strategy of early initiation of therapy is not associated with improved survival and may be associated with harm in terms of an increased need for kidney replacement therapy. Although the severity of fluid overload is strongly associated with adverse outcomes, there are insufficient data to conclude that a specific degree of fluid overload should be used to start therapy. And there's absolutely no data to support the use of kidney replacement therapy for cytokine modulation. And I find it ironic that we are probably in 2022 back to where we were in 1986. In 1986, after a study by John Conger and colleagues that demonstrated that an earlier start was not associated with better therapy, the teaching was earlier is better up to a point, but there is no real benefit to starting kidney replacement therapy for the majority of patients before the BUN is in the range of 90 to 100 milligrams per deciliter. And I think the current data says, well, maybe that's 112 milligrams per deciliter, but there's not a whole lot of difference between 90 to 100 and 112. So I think we've strengthened our evidence for taking the same approach to management. But we now know a lot more about this in terms of the degree of data, and the population that we're looking at has actually changed dramatically between the 1980s and now, with our patients in the ICU being substantially sicker. So with that, I thank you for your attention. Dan. So, I think that's a good point, and one of the points that has been, going back to Paul Teshin's statements about we shouldn't discount the benefit of starting earlier just because patients who you don't start early are still going to survive. But in fact, for the majority of patients, we can manage them, giving them adequate nutrition, giving them the antibiotics that they need without that earlier exposure. And we shouldn't forget that kidney replacement therapy, whether it's intermittent hemodialysis or continuous therapy, isn't benign. When we have analyzed the data from the studies of intensity of kidney replacement therapy, so there's no difference in terms of timing, and limit the analysis to studies that only used continuous therapy. I don't want to get into the debate about continuous versus intermittent. Those patients treated in randomized controlled trials who received the higher dose therapy, so 20 versus 35, or 25 versus 40, or 20 versus 35 and 40 milliliters per kilogram per hour, had less recovery of kidney function, prolonged time on kidney replacement therapy. My take from this is that kidney replacement therapy carries a toxicity to the kidneys, the same way that we know that mechanical ventilation harms the lung. It's necessary to keep people alive, but we should use it as judiciously and as minimally as possible. Doc? So we don't have pediatric data. All of the studies, whether it's Elaine, Akiki, Ideal, START, excluded individuals either less than 18 or less than 21. So I can't give you evidence that says that in your neonate, you should follow the guidance from adult literature. Adolescents, they're probably more like the adults. But infants, I have no idea. We need data in that population. But I would caution that the observational data that says, in terms of fluid overload in particular, and that was, the Sutherland data is pediatric data driven, based on Stu Goldstein's initial studies, may not be strong enough data to really guide therapy. And who knows whether they know better or not. The role of biomarkers to prognosticate what's going to happen really is very limited. I mean, we have NGAL that is available not in the United States but elsewhere for clinical purposes. It's urine NGAL. And in the United States, we have NephroCheck, which is tissue inhibitor of metalloproteinase 2 IGF binding protein 7. I've never quite figured out. I think the University of Pittsburgh has some IP with that. I have nothing to do with that. So I am not blown away at this point by NephroCheck as a prognosticator. My biomarker that I tend to use is very low tech. Furosemide and urine output. If the patient responds to furosemide with a brisk urine flow, then I'm going to be a little slower in starting. But we need better prognostication to tell us which patient has severe injury and is going to turn around quickly, and which patient doesn't have severe injury or has other markers that show that recovery is imminent. And if we could prognosticate the future, we all would have gotten the lottery tickets for the $2 billion Powerball, and we could foretell what would happen for our patients in 2 to 4 days, or even a longer time frame. And unfortunately, we still don't have that ability. So, there certainly is a component that's hemodynamic. But when I focused when I said, if we look just at the patients receiving continuous therapy, where the only difference is, what the dialysate flow rates are, there should be no difference in hemodynamic stress with that. Which raises the question, really, what's driving this? Is it some degree of bioincompatibility? Bioincompatibility of the fluids, bioincompatibility of the exposure to the extracorporeal system. Our circuits are much better than they were 20 years ago, 30 years ago, but there is still some degree of activation of inflammatory mediators, and what that is doing in the kidney, when we don't know. And it would be nice to have biopsies done during the treatment to figure out what's happening in the kidney and why this is the case. I don't know why. I don't have a good explanation other than this hand waving as to why there is worse recovery of kidney function associated with the higher dose of continuous therapy. It's going to require someone a lot smarter than me to figure that out. That was in the observational study, and that was baseline pressor. No, the pressor dose was associated with increased mortality. The higher the pressor dose, the higher the mortality. So it's probably a marker of severity of illness.
So I'm just saying, they were not, their blood pressure must have been low, all if they were on pressor, right?
Well, they were started because they were more hypotensive. They probably had more severe vasoplegia from underlying sepsis. The key point there wasn't the higher mortality associated with the higher pressor dose, but after adjusting for that in this multivariable analysis, that the degree of volume overload at the time of start of continuous therapy was no longer statistically significant, that these other factors were actually the drivers, suggesting, as I drew in the model, that the key is the severity of illness driving the mortality in the patients who are more volume overloaded, not the volume overload per se.
And the other one was, those of us who are not doing research in nephrology in this country, we tend to always use creatinine as a measure. But I was struck by studies that you said the criteria was nanomoles of urea versus, and so because we know many more things can affect the BUN than creatinine. So help us with that, with why the nanomoles, and thank you for telling us about the quick conversion.
So in Europe, they measure urea rather than blood urea nitrogen. So if you're measuring it in milligrams per deciliter, as occurs in, I guess, in England, the absolute number is higher. And, to get from BUN in milligrams per deciliter to urea in millimoles per liter, it's just divide by 2.8. We have traditionally, although we measure kidney function based on the creatinine, looking at accumulation of the metabolic toxins, urea seems to be the better surrogate, even though we know that urea per se is not the toxin. It parallels it's better paralleling the accumulation of other toxins, although it's imperfect.